Fernanda Akoiso, good afternoon and welcome to the Academy for Health Equity seminar series. We'll just wait a couple of minutes until 12:15 and maybe another minute for late arrivals. Fernanda, welcome to the Academy for Health Equity seminar series. My name's Lorelei Jones. A very warm welcome to Kat Ford, who is the research lead for the Public Health Collaborating Unit here at Bangor University and part funded by Public Health Wales. Kat's research is in violence prevention and adverse childhood experiences, which you'll be talking about today. So thank you very much for joining us. If you have any questions, please do pop them in the chat and we'll get to these at the end. Diolch.
You happy for me to start, Lorelei?
I am.
Perfect. Fernanda, good afternoon, everyone. Thank you for the introduction, Lorelei. I'm Kat. I'm a researcher, as Lorelei mentioned, based in the Public Health Collaborating Unit with Bangor University in the School of Health Sciences, and I work in very close collaboration with Public Health Wales NHS Trust, who are a World Health Organization collaborating centre on investment for health and wellbeing. So I'm going to talk to you today about some research that we've done in Wales, and some of it kind of touches England too, spanning the last decade really. So I'm going to talk about adverse childhood experiences, which are called ACEs. I'm sure some of you might already be familiar with this concept, but this is really research that looks at stressful experiences in childhood, so before the age of 18, that can either physically directly affect a child, such as physical abuse, or can affect the home environment where they're growing up. So, for example, having a parent who may have drug misuse or alcohol misuse, or having a family member who's incarcerated. What the global evidence base on ACEs has evidenced is that these are one of the strongest predictors of poor health and well-being across the life course. They affect child development, they're linked to a range of health harm behaviours which I'll cover, a range of poor health outcomes across the life course, poor education and employment outcomes, and also a range of illness. And what we also see in the research is that there's a cumulative increase in risk. So the more adverse child experiences people have experienced, the higher the risk of some of these adverse outcomes. But what's important, and I'll come on to, is that the research I'm talking about is not causation. We're looking at associations. Majority of the research is cross-sectional, but also that ACEs are preventable and their impacts can be avoided, but also not everyone who experiences adversity in their life does have negative health outcomes, and we'll come back and talk about resilience a little bit later on. So as I mentioned, I've been working on ACEs in Wales over the last decade. So in 2015, back then, we ran the first national ACE survey in Wales, where we did a general household population survey of 2,000 adults aged 18 and over. An interviewer attended their household residents to ask them to complete a survey. And we found, this is the ACE prevalence, we measured 9 ACEs typically. We found around 20% reported verbal abuse, over 1 in 10 reporting physical abuse, around a quarter reporting parental separation or divorce, and between 15 and 18% reporting kind of having someone in the household with problematic alcohol use or mental illness. And the least prevalent ACE was having a family member incarcerated. We've conducted a further 4 national ACE surveys in Wales. In 2017, we repeated the methodology and looked at measuring ACEs and resilience, and that was again around 2,500 adults that we spoke to then. We conducted one during COVID, which was online and telephone. We did the ACE and Healthcare survey, which was an online sample, and we did another door-to-door survey in 2023 during the cost of living crisis. So we have a relatively large data set of data that we've collected in England and Wales, examining people's exposure to ACEs. And what we find is that ACEs are actually quite common. Half of all adults typically in the general population that we speak to report having experienced at least one ACE growing up, and over 1 in 10 report 4 or more ACEs. So they are common across the population. And studies have been conducted elsewhere, obviously. So here I've got the prevalence kind of in the UK nations, for Wales there, but also you can see a similar prevalence in England, slightly higher prevalence of 4 or more in Scotland of 15%. But international studies have been conducted globally to look at ACE prevalence. Some of the methodology slightly differs. Sometimes they're cross-sectional surveys like what we typically used. Some of them are from registers, health registers, but there is a variety of ACE prevalence, as you can see for South Africa here. We've got around over a third reporting having experienced 4 or more ACEs, with nearly 9 in 10 reporting any exposure. So ACE prevalence does vary, and obviously there's cultural increases in risk as well. And what we do know is that ACEs co-occur. So most children who suffer an ACE are likely to also suffer other ACEs. Using data across our samples from England and Wales, looking at people who reported having a household member who abused alcohol, we found that over 1 in 10 reported this ACE, and over half of them reported having experienced 4 or more ACEs in their childhood. And here, when we look at the other ACE types that people reported, you can see that the more prevalent ACEs are verbal abuse, parental separation, domestic violence, with over 4 in 10 reporting those, and physical abuse and mental illness in the household. So we know that ACEs co-occur. And across our data, we know that ACE exposure has been linked to a range of the uptake of a range of health harming behaviours. So here in the graph, you can see the proportion of those reporting health issues by ACE count. So for example, if we pick mental illness as an example, around 23% of those with no ACEs report lifetime poor mental illness, and that increases to 64% of those in 4 or more ACEs. A range of health harm behaviours, so cannabis using and smoking, poor diet, also being a victim of violence, or for also having perpetrated violence, increases from around 2% of those in no ACEs to 14% in those with 4 or more. So a range of negative health issues across the life course. And when we adjust our analysis to see the risk of these outcomes, and when we account for other influences like participant demographics, measures of deprivation, we find the risk of outcomes is higher in those with 4 or more ACEs compared to those with none. So on here, you can see that compared to those with no ACEs, Those with 4 or more are over 2 times more likely to report being a current high-risk drinker or a smoker, 4 times more likely to report low mental well-being or current mental illness, over 6 times more likely to report lifetime alcohol dependency, are 8 times more likely to report ever been incarcerated, and also 8 times more likely to report in the last year having been a victim of violence. But we also find, compared to those with no ACEs, those with 4 or more are much more likely to perpetrate violence, so the increased risk here by 10 times, and also to have ever reported lifetime suicide attempt. But ACEs haven't only been linked to poor health behaviours, but also to the development of disease. We looked at individuals reporting being diagnosed with at least one of the 5 major diseases. Here that was cancer, heart disease, respiratory disease, liver disease and type 2 diabetes. And I've got the cumulative percentage of those who develop disease by age shown on the graph here. Those with 0 ACEs in the kind of tealy colour at the bottom line, and those with 4 or more in the top line. And what you can see here is that disease prevalence is doubled at age 55. So it's 22% in those with no ACEs and 44% in those with 4 or more ACEs. But what we can also see that's interesting is those with 4 or more ACEs are actually developing disease 10 years earlier. So you should be able to see here the pink line at age 39 years is the same cumulative percentage for those at 49 years in those with no ACEs, and the same again at 49 years of age. And it's not just our evidence from England and Wales that has shown this. This evidence is supported by a strong international body of evidence showing that ACEs can harm across the life course. So in 2017, there was a global review of international studies on ACEs covering 37 studies across 17 different countries. And the meta-analysis from this systematic review found that ACEs increased the odds of poor physical health. So again, compared to those with no ACEs, those with 4 or more were 3 times more likely to report respiratory disease, for example, were over 4 times more likely to report mental illness, so depression or having low life satisfaction. There was increased risk of physical inactivity and measures of obesity, increased poor outcomes for sexual health, so early sexual initiation, reporting a teenage pregnancy, multiple sexual partners, and also having an STI. And also linked to substance misuse. Over 5 times more likely to report illicit drug use or problematic alcohol use. And also violence, I've already mentioned. So over 7 times more likely to report being a victim of violence, 8 times more likely to report having perpetrated violence, and over 30 times more likely to report lifetime suicide attempt. And we were interested in then understanding the financial burden of ACEs. So we took the ACE prevalence in England and Wales from across our studies, and we looked at, using that data, the relative risk for 4 health risks: smoking, being overweight or obese, alcohol use and drug misuse, and looked at 9 causes of ill health, so anxiety, depression, heart disease, other mental illness, cancer, respiratory disease, violence, type 2 diabetes, and stroke. And we did a country level ACE prevalence was calculated to generate country level population attributable fractions due to ACEs. We applied these fractions to the 2019 estimates for DALYs, so the disability adjusted life year from the global burden of disease. And we found the cost of ACEs in Wales. So shown here, we've got the combined annual cost of ACEs to society of £2.2 billion back in 2019. Obviously, this varies across health risks and causes of ill health. You can see smoking here for 467 million, and cancer 476 million. And when we look at this, the cost is equivalent to around 3.5% of our GVA for England and Wales. And we followed the same methodology and conducted a systematic review of these health risks and causes of ill health, and then combined analysis of data from European studies measuring the prevalence and impacts of ACEs to estimate the annual health and financial burden of ACEs across 28 individual countries. As I mentioned earlier, across countries, the measures used to understand and record ACE exposure does different. So in Sweden, they use population registers. Some of these populations are based around student populations, so kind of miss certain populations. But here you can see the cost of ACEs in 28 European countries, and this is shown as the equivalent percentage of the GDP, the gross domestic product. And really, the reason we do this is it's important when advocating for intervention and change to understand the costs of leaving ACEs unaddressed, and the savings to health and the wider economy that could be done if ACEs were prevented or if we mitigated their negative impacts. And we know certain population groups are at higher risk of experiencing adversity. I led in, I think it was 2018 or 2017, the first UK study of ACEs within a prisoner population. This was in HMP Park, which is based in Bridgend in South Wales, for those of you that aren't familiar. It's a Category B prison, where we interviewed 470 people who were aged 18 to 69, who were not currently on an ACT, which is the current safeguarding used at the time within the prison. It's conducted, I think it was 2018, sorry. We conducted a face-to-face questionnaire which asked them about their exposure to 10 types of ACE. So the 9 covered earlier, and we also asked them about experience of neglect. We asked them how many children they'd fathered, and the age and gender of each child, and to also estimate how many ACEs each of their children had been exposed to. We found a really high prevalence of ACEs here. So as you can see, that's shown in the graph with the prisoner sample in yellow compared to the male, compared to the Welsh general population. And what we found was over 8 in 10 in this sample reported experiencing at least one ACE during their childhood. The most common ACEs were parental separation, domestic violence, and experience of child maltreatment. And you can see here the prevalence kind of mirrors that of the general population. So only 16% in this sample reported no ACEs, compared to 12% of the general population who experienced 4 or more, whereas in the general population, 51% reported no ACEs, where we had 46% reporting 4 or more ACEs. And as part of this study, we were interested in the intergenerational transmission of ACEs. As I mentioned, we asked how many children people had, and of the sample, 294 prisoners had fathered children, and that related to 671 children. And what we found was that children of fathers who had 4 or more ACEs, compared to those with none, were over 6 times more likely to have 4 or more ACEs themselves. And what we found that their exposure as a child to each individual ACE type, except sexual physical abuse, was associated with their father having had experienced the same type of ACE in their childhood. So we found a real strong intergenerational transmission of ACEs in that study. To add to that, we conducted a Welsh survey, a telephone survey of adults aged 18 over between December 2020 and March 2021. This was on telephone because it was conducted during the national COVID lockdown restrictions. And we wanted to measure the relationship between ACEs and health and behaviour. We used a sample that was still stratified by kind of age to try and get a representative sample across health board and residential deprivation. For analysis, the sample was limited to parents who reported that they had children currently who were aged under 18. So we had a sample of 720 people. And we asked them about their child physical punishment using 2 questions, asking how many times participants had ever smacked or slapped a child for misbehaving, and whether they'd smacked or slapped a child to punish them for their behaviour in the last 12 months. And we found that overall 28% of parents reported having ever physically punished a child, and almost 6% reported having done so recently, so within the last year. And we found that child physical punishment use increased with the number of ACEs that parents reported. So that's shown on this graph here between having ever punished a child and in the last year. And parents of those with 4 or more ACEs were almost 3 times more likely to have ever physically punished a child and 11 times more likely to have done so recently. Sorry, just scrolled through by accident there. We conducted another survey between November 2022 and March 2023. This was during the cost of living crisis. Again, this was a national cross-sectional survey which was done face-to-face on people's doorsteps. And we used a random quota sample of households here, again stratified by health region and deprivation quintile. And we looked at people's perceived inability to cope financially during the cost of living. And what we found is people's perceived inability to cope increased from 14% of those with no ACEs to 52% of those with 4 or more ACEs. And these relationships with ACEs remained after we controlled for socioeconomic and demographic factors, so including deprivation. And those with 4 or more ACEs were over 3 times more likely to perceive that they would be unable to cope financially, and correspondingly almost 3 times more likely to report substantial distress and anxiety, and over 3 times more likely to report negative impacts to their mental health and physical health and family relationships. And we know that deprived populations are recognised to be disproportionately impacted by the rising cost of living, but what this study identifies is that adverse child experiences can be an additional level of vulnerability that can affect individuals across all socioeconomic groups. During COVID, we conducted another survey. This was a telephone sample. It was undertaken during a period of COVID-19 restrictions. Again, Welsh samples, Welsh adults. And we asked people around their trust in NHS information, if they felt they were unfairly restricted by the government during the COVID lockdown, social distancing and face covering restrictions and adherence to those restrictions, and also their vaccine hesitancy around the COVID vaccination. And we found those with 4 or more ACEs were more likely to report low trust in NHS information, were more likely to report that they didn't follow the restrictions, and were also more likely to report vaccine hesitancy. This analysis actually adjusted for having had COVID-19 infection and also for chronic disease, recognising that certain population groups might be more at risk of ill health related to COVID. And we found that those with multiple ACEs in their childhood were 2 times more likely to report that they felt unfairly restricted by the government. They were also more likely to have braked the restrictions. And they were 3 times more likely to feel that social distancing should end, but also to report low trust in COVID-19 information. And we also found that they were likely to report COVID vaccination hesitancy as well. In relating to that and the understanding of how our experiences as childhood may impact how we engage with services and restrictions, and understand that back in our second ACE survey, we actually looked at perceptions of service supportness. And what we found with individuals with multiple ACEs reported an increased prevalence of services in their perception not being at all supportive. That's shown here in kind of the pale lilac at the top of the coloured bars. And this pattern was true across a range of public sectors and also charities. You can see here in the middle the proportion reporting that they thought the police were not at all supportive was much higher in those with 4 or more ACEs compared to those with none, and the same pattern for those who did find them very supportive was higher in those who had experienced no childhood adversity. And we were really interested in how our child experiences may impact the trust in services. So we did a couple of surveys. One was an online sample using the panel provider Prolific, and that was conducted with a sample of people living in England and Wales. And we also collected data through a national household survey, again in November 22 to March 2023. And we asked about ACE exposure, but we also asked about trust in health, social, police, charities and government. We asked about people's health experiences and their trust in general information provided by a variety of professionals and sources. We measured trust using the question on a scale of 0 to 10. How much do you trust, with 0 being not at all and 10 being completely, for a range of services. And here you can see the change in levels of low trust, which was categorised as below the midpoint of the scale, so scores under 5 as having low trust. So individuals were more likely to report low trust in the police, for example, 17% in those with 0 ACEs compared to 44% of those with 4 or more. And when we adjusted for that in our analysis and adjusted for participant demographics and deprivation of residence, we found that those with 4 or more ACEs were nearly 4 times more likely to report low trust in the police than those with none. And again, oh, there we go. We asked about trust in health information from different services. So we were interested in where people get their health information from. And you can see here that low trust in health information in the NHS rose from 13% of those with reporting no ACEs in their childhood to 24% in those who reported 4 or more. So a history of ACEs was associated with lower trust in supporting institutions, systems and a range of professionals as well. And obviously this is important for how we also communicate to individuals who may be vulnerable, but also for those who may have experienced adversity. Individuals with adversity can also report feeling less comfort in certain healthcare situations. So here, compared to those with 3% of those with no ACEs reported low comfort in GP surgeries compared to 8% of those with 4 or more ACEs. And you can see particularly here for dentists, 5% of those with no ACEs reported low comfort, whereas 13% of those with 4 or more ACEs in their childhood reported low comfort in using these settings. And relationships with healthcare settings and providers, we found that they were also sorry, this is going around the same. There we go. We also found that they were more likely to report that they felt that healthcare professionals don't care about their health, or that they do not understand their problems. And this is interesting when we also see in those who've experienced multiple ACEs that there's lower levels of medication adherence. So 17% of those with no ACEs reported low medication adherence, so taking medication as the guidelines suggest on the packet or as described by a health professional, compared to 28% in those with 4 or more ACEs. This is important as a population who are likely to require treatment due to ill health. And the acceptability of advice and messaging is likely to vary by agency, as we've seen. And individuals are potentially more likely to require advice and treatment, but have less trust in health professionals and less adherence to the guidelines that they're given. We did look as well in trust in lower in online sources versus in person, and that was quite interesting, but I haven't got those findings on here. But what we're finding is that engaging individuals with ACEs may also help to kind of break these cycles. And we know that ACEs can increase individuals' risks of poor health across the life course. For children that suffer household-based ACEs, experiences in other settings, such as the schools, may have the potential to either exacerbate or mitigate the risks of poor health. However, few studies had examined such effects. So we did a national survey again of just under 2,000 adults in November 2022 to March 2023. And we were interested in people's experiences at school, so where they've been bullied and their perceptions of school belonging. And we found the proportion reported both having been bullied and low school belonging increased with ACE count. Here you can see it's 6% in those with 0 ACEs, and 51% of those with 4 or more reported this poorer school experience. And we found that this was associated with increased risk of low mental wellbeing, mental illness, and violence victimisation. In individuals with 4 more ACEs, the adjusted prevalence of current mental illness reduced from 44% of those reporting as having both been bullied and lower school belonging to 19% in those reported not having been bullied and higher school belonging. So you can just see there. So for children who grow up in adverse home environments, exposure to further adversity at school may amplify the risk of the poorer health and life outcomes. However, what's really important to know is schools are a good setting for children who lack safety at home and support at home to help recover from stress, to develop resilience and access support. And there's a range of work going on in Wales around trauma-informed approaches to schools that recognise the impact of adversity and to support children to overcome that and potential to improve not just their educational outcomes, but life course health outcomes. And this is important because the first 1,000 days of our lives are really important for brain development. It's when you develop your attachment style. It's where your brain grows to 80% of its adult size. And when any of us counter a threatening situation, so stress, if it's a bear in the woods, for example, the healthy response to that is to have the threat and to fight, flight, freeze, flop. You may feel sick. I'm sure lots of you experience this if you're giving a presentation or doing a job interview. You feel desperate to use the toilet. That's because your body is actually preparing itself to make itself lighter to be able to escape that threat, to run away from that bear. But what we find is that chronic stress imposed by ACEs can lead to biological adaptations, which in the short term help children survive, but in the long term have impacts on health, education, other outcomes, and that's having this heightened state of alert where they're not returning to kind of recovery and at rest. So that life-preserving part of their system, the part which is telling you to run away from that bear in the forest, is always prepared for the potential for experiencing more trauma, and that has a wear and tear on the body and impacts our stress hormones, which can impact our brain and psychological development and our learning, our memory, our attention. And so ACEs have been linked to poor child development, so lower levels of language, literacy and skills development and social skills, reduced relationships between both peers and also teachers and feeling less connected at school, increased attention problems, involvement in bullying. Obviously, we've already covered a range of health harm behaviours and antisocial behaviour, but also increased school absenteeism, lower school attainment and qualifications. And in the long term, we've also found ACEs are linked to poor employment outcomes and lifetime earnings. And as I mentioned right at the beginning, not everyone who experiences ACEs in their childhood have negative outcomes from it. And a key factor that we're learning for that is the resilience. So resilience is defined as the dynamic process of adapting and responding well, individually or collectively, in the face of challenging circumstances such as economic crisis, psychological stress, trauma, tragedy, threats, and other significant sources of stress. It can be described as an ability to withstand, to cope, or to recover from the effects of such circumstances, and the process of identifying assets and enabling factors. And we've done research that's shown that resilience in both child and adulthood can help individuals cope with having experienced adversity and can help avoid or mitigate the harmful effects that are associated with it. And there are a range of types of resilience. We talk about our individual resilience, so having those life skills to kind of overcome adversity, but they could be some of the key factors that some of our researchers found is relationship resilience, so having a trusted, supportive relationship with another adult. That doesn't necessarily have to be another family member. It could be a teacher, a sport coach. But we also see resilience within communities and also within systems, which I'm sure a lot of you are familiar with. So, you know, capacities of healthcare systems to absorb or respond to stress as well. And we know that ACEs have important consequences for population health. Our research in Wales actually led to a change in government policy. And back in, I can't remember what year this was published, but the Welsh government made a commitment to policy to commitment for action in Wales to address adverse childhood experiences. So in the national strategy, the prevention ACEs and creating ACE-aware services was given as a public priority. And ACEs can be addressed across the life course. We can look for programmes to prevent childhood abuse and maltreatment and ACEs. We can look to respond to them when they occur. We can also look for interventions that may build resilience, as I mentioned, give individuals the resources to cope with these things. One of the key things there we found was participation in childhood sports and also having an always available trusted adult. But we can also look at developing the organisations, sectors and systems that respond to individual to make sure they're trauma informed and don't further re-traumatise individuals, and that they provide support to those who've been affected by adversity. I haven't been involved in this piece of work, but it's important to kind of recognise it. This handbook that my colleagues produced, which aims to support action to address ACEs. It aims to provide professionals and organisations with guidance on implementing work to prevent ACEs, to build resilience and develop those trauma-informed sections. It explains what you need to know about ACEs, resilience, trauma-informed organisations, drawing from evidence-based interventions and policy, and kind of uses our evidence base to show how you can take that to move towards intervention and action. So we have got examples in Wales of the steps for implementation. So part of that obviously is the research. It's assessing the current situation, understanding the problem, raising awareness and advocating for change, partnership working, selecting appropriate interventions, providing the cultural change to embed those, but also important is evaluating action and scaling up and sustaining that. So we've got good examples of that in Wales with partnership working, particularly around ACEs and policing, supported through the ACE Hub Wales and the Early Action Together programme, which ran training, particularly in the criminal justice sector in Wales, but also to schools, which has been evaluated and is currently still being developed. And what this handbook shows is it has a summary of evidence of what we know that works across strategies to mitigate the impacts of ACEs and the risk factors for this. So this table here uses tick marks to indicate which strategies have been shown to be promising or effective in preventing specific ACE types, but also building resilience as well. It's important to note that those without tick marks may be effective, but there's just currently less evidence to support those approaches. And here you can see how some of these affect multiple ACE types. So it's kind of highlighting that prevention effort may look to address single types of ACEs, such as the misuse of alcohol, but at a high level, some of these strategies actually work across multiple types of ACEs. Really strong evidence base, for example, is highlighted here for strengthening families, from parenting programmes, also school-based intervention programmes. It's just to highlight that report. And in Wales, we have the Trauma-Informed Wales Framework, which is a societal approach to understanding, preventing and supporting the impacts of trauma adversity. This aims to kind of go across different levels of society and different sectors for people to be trauma-informed, to be trauma-aware, for trauma skilled, and for those who deal and work with people who may have experienced trauma to be trauma skilled and enhanced, and obviously specialist treatment and interventions. But it's around understanding the universal and community approaches and response to trauma. So there's a lot of work going on in Wales, led by the ACE Hub in Wales, around the trauma-informed framework. And I just also wanted to finally highlight there's obviously the individual and relational risk factors, but there are also social determinants of violence. I've also done some research into the commercial determinants of violence, but I'm not going to talk about that today. But if anyone's interested, I'm happy to share some work we've done on that recently. But colleagues have worked with the World Health Organization to publish this INSPIRE report, Preventing Violence Against Children. And this is a framework for strategies to reduce violence, the social determinants and the risk factors for childhood violence, as it's important that we need the right conditions in society to eradicate violence against children, and understanding that the importance of poverty and inequality in this. So this report is based on a systematic review of global evidence. It sets out policies and laws, again, which are at quite a high level, but that can support the rollout of interventions included with the INSPIRE framework, which is the 7 strategies for preventing violence against children, led by the World Health Organization. And this is evidence basically that for things that either directly prevent violence against children or can positively influence the determinants for children's risk of experiencing violence. So for each policy and law, the report presents a rationale for why it's included and a summary for the available evidence, focusing on areas where there's greater levels of evidence too. So I'm conscious I've not got a lot of time left, so just in summary, what research has shown us is ACE is a really strong predictor of poor health outcomes across the life course. And that across the life course, therefore, we need a consideration of preventing ACEs in the first place, recognising the benefit to a large range of sectors and the financial benefit if we could prevent ACEs from happening in the first place, but also important in building people's resilience, so to help buffer those negative effects for those who do experience ACEs, to help prevent these negative effects and benefit the health, but also the response to those who have experienced adversity, so making sure services are trauma informed. And there's a lot of work going on in Wales, as I mentioned, particularly in health, social, education and criminal justice sectors, and also the benefit to these sectors from starting health on the right trajectory. And then obviously, as I mentioned earlier, that we see that ACEs are intergenerational, so preventing these experiences don't just impact the individual, but they may also have a positive impact for future generations in Wales. I just want to say diolch, thank you to those who've participated in the research, but also to my colleagues who I work in close partnership with, particularly Professor Mark Bellis and Professor Karen Hughes as well, just to recognise their role in a lot of the research that I'm talking about. So thank you for listening, and I think we've got a few minutes if anyone has any questions.
Thanks very much, Kat. And thank you, Imi, who's just popped a message into the chat that if you'd like to either put a question into the chat or just unmic if you have any questions for Kat.
I'm happy to pop the links to any of these resources in the chat if anyone likes, or the majority of them available from my profile page on the Bangor University website as well.
Oh, thank you very much. I think everyone probably... Oh, Sally, would you like to come in?
Oh, yeah, sorry. I realised that I've got you on the wrong screen, so you're gonna get a terrible side profile, which is awful. Hi, I'm Sally Johnson from Wiltshire Council Public Health, with a lead focus on children and young people. I guess I'm interested, it's really helpful to, I'm very aware of this study, but it's really helpful to get all of these updated bits of data and evidence that you've been sharing, so thank you. Just looking at some of the work that sort of Wales are doing, is there research kind of coming out in terms of the impact of that work? So we're doing work locally around attachment-aware trauma-informed practice. I think there's a really important element for me about focusing on that importance of attachment-aware. So not just taking it down this sort of trauma-informed end necessarily, but it's a massive culture shift, actually, is what I observe. And so I'm really interested to know if there's any research or evidence coming out about how that's actually working in practice. So we're doing something systemically in Wiltshire and have been since 2019, but it's a bit of an uphill battle, I have to say, sometimes.
Yeah, there is some coming out. There's been some evaluations done, particularly of some of the trauma-informed framework, and I'm aware that we're currently developing, for example, an evaluation framework for some trauma-informed training that's going to be run by Traumatic Stress Wales, and that's kind of at the when I mentioned the trauma-informed framework, there was that lovely kind of diagram where it goes pink out to like a kind of purple colour, and it's for those services and individuals who may be responding to and working with people who've experienced trauma. So we're trying to kind of wrap the evaluation around these so we can look at long-term impacts, particularly where it's trauma-informed training, and we're trying to identify evidence of good practice. We're currently doing a review around the evidence for trauma-informed police custody, for example, so we can kind of share that good evidence and the knowledge base as well. So if you're aware of anything locally, it would be great to see it as well.
Yeah, okay. No, thank you. I think my experience is that organisations sometimes will kind of own the label of being trauma informed, but I'm never quite sure how that's translating in practice. And for us, we're looking at that piece about systemically embedding it. So it's not just about training staff, because actually if your managers haven't had the training, and if you're not looking at your policies and your protocols through the same lens, then you've got this kind of, in fact, you've got a potential rub actually between what's happening on the front line.
Yeah, it's about that wider organisational change and not just the front line. So I completely agree with you. Yeah.
Okay, really interesting. Thank you.
Thanks, Sally.
Kat, can I just check? And Imi, I mean, we have the recording will be available on our YouTube station, and are we also making the slides available?
Yeah, that's fine.
Yeah, okay, so that'll be fantastic, because there's so many resources on those slides that and so many, you know, practical, helpful, insightful reports that I know I'll be following up on, and I'm sure other people here will want to follow up on as well. I don't think we've got any more questions in the chat. Does anyone else have a question for Kat?
If anyone does any questions, I'm more than happy. I can pop my email in the chat if anyone wants to drop me an email for more information or anything. That's absolutely fine.
Okay. Sorry, where could we find the slides? I don't know if I missed that. Was it a website?
I can send them, if I can upload them either to this chat at the end of the meeting, or I can send them out via email if you want to pop your emails into the chat before you go.
That's brilliant, thank you.
Okay, and also just to answer Rachel's question, this session will be available on the YouTube channel, which I've just popped in now. That should be ready next week, Monday.
Great. So do have a look at Kat's profile to see publications, and we'll put the slides in this chat, in the Teams chat as well for you. So thank you very much. I'm going to do, if I can, big round of applause.
Thank you all for coming and for listening.
There we go. Thank you very much, Kat, for your time today, and thank you everyone else for coming, and please do join us next month for our next session, and I'm looking in the chat, which will be Emily Peckham on oral health and mental health. Thanks very much. Hoyle.
Yeah, thank you.
Thanks, everyone.
Thank you.